Welcome to today's session. We'll get everyone to just introduce yourselves in the chat as people are signing on. So hello from South Lake, Caitlin, Tommy Merritt from West Toronto, Christina Clark, welcome. We have someone from West Toronto, Joanna Hicks from Kuchiching, Jason from Rainy River, welcome everybody. Great to see everybody signing on. Some people from let's see, so fast. Oxford and area OHT, Hamilton, ANHP, Melanie, welcome everybody. Brian, welcome, glad to be here. We have Marsha from Muskoka OHT. Okay, lots of people joining in. So today's topic, we're looking at health outcomes, patient-reported outcomes and proxy patient outcomes. And again, everybody, as you're signing in, let us know who you are and what OHT or other organization you're from. Lots of you are doing this now. So again, welcome from Bradford, Brant, Norfolk, OHT, still people signing in. And I will just remind you, if you can set your response to everyone in the chat box, that way it won't just go to hosts and panelists. And when we have some discussion later on, we can ensure that everybody can see your comments. So again, make sure you're introducing yourself to everyone, and later when we chat that it goes to everybody as well. So to get started, I want to acknowledge this land in which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. And today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. So we'll start with a poll, as we always do, to kind of get a sense of who are the newcomers to this webinar and who's attended previous webinars. And still, if you're signing in, I'll get you to introduce yourself and your OHT. Anne, are you able to launch the poll? Great, thanks. So have you joined this HSPN webinar previously? So our last webinar, we had, I believe, about 78% had joined us before, and I guess 22 were new. So it looks like we've had, most of the people are starting to fill out that poll. So we'll give it a couple more seconds and then close it in 5, 4, 3, 2, 1. So looks like pretty similar results. Almost 80% have been here before, but we have 20% who are newcomers to the event. So welcome, and if you missed previous ones, they are available on the HSPN website. So our topic for today, looking at health outcomes. So we're going to start with looking at patient-reported outcomes, and each of our subsections will have a view on equity analysis. So that one will focus on social determinants of health. And then our next section, we'll hear about using health system data to understand health outcomes. And there for the equity analysis, we'll focus on the material deprivation index. So today's event, we have some very common faces that will be speaking to you. So we'll be hearing from Dr. Walter Wodchis and Dr. Ruth Hall, who are both the co-leads for our OHT central evaluation. And before we get started, I'm gonna just highlight again the quadruple aim. So this has been our an orienting framework for OHTs that the ministry has adopted for evaluation. And it's been the focus of the last few webinars, and this one and one more to come. So we're taking a trip around the quadruple aim. HSPN is enabling all aspects of the quadruple aim, and that's why we focused on highlighting one of each. And just to note that at a mature state, Ontario health teams are expected to achieve some of these aims. So better patient population health, better value, better patient, family, and caregiver experience, and better provider experience. So today, we're focused on health outcomes and better patient and population health. So with that, I'll turn it over to Walter to take you through some info on patient-reported outcomes.
Oh, thanks very much, Kaileah. What a lovely introduction, and so nice to see everybody joining us today in our webinar on patient-reported outcomes. It was such a great idea Kaileah had a couple months ago that we should really take a tour around the Quadruple Aim, and many of you have joined us over the last couple months as we looked at patient experience and then and provider experience. And today we're turning it to health outcomes. And I'm going to talk about the patient-reported outcomes, and then Ruth about our derived outcomes from health administrative data. The next slide, Kaileah. Our work in this space is generated from the patient survey. We do not systematically in Ontario collect health outcomes at the point of care. And so we felt that it was essential, as many providers had identified PROMs and PREMs, patient-reported outcome measures and patient-reported experience measures in their original applications as being key indicators that we really needed to make some space and create an opportunity for OHTs to be able to collect in a common way patient-reported outcomes and experience. So, we started this off with essentially thinking about what the 6 attributes were, and I think we had Carrie Koleski drop in and explain where they came from in the origin. And we talked about the first 4 of these around patient-reported experiences, and we had our colleagues from South Georgian Bay and how they were using it with their patient and family council to push forward in this space. Today, we're going to talk about, on the outcome side of that patient-centeredness, is really independence and well-being. And here we're going to capture it through patient-reported outcome measures. The other components of this survey include health services use and digital and transitions of care, and we're not going to talk about those today. We do collect, however, and we collect for the purpose of using key demographic and sociodemographic measures. So it's not just for administrative purposes, not for statistical purposes, it's actually to inform how we plan care. And this includes age, gender, and race and ethnicity. And today I'm going to have a special focus on social determinants of health, including income, food, and housing security, as well as social isolation. And most of you will have not seen these results already. And so I think you may be maybe not overly surprised, but I'll say that I was a little bit surprised at some of the strengths of the relationships that we're seeing with social determinants, particularly in the outcome measures. Next slide, Kaileah. So our overall PROM, and there are many patient-reported outcome measures, the one we selected is the Euroqual 5-dimension, 5-level measure. We selected this particular measure of PROM for many reasons, but the 2 primary ones are, one is its brevity. It is about the shortest multi-dimensional health-related quality of life measure out there. The next closest would be, a 12-item or more. And it's also commonly used in other components of Ontario, such as in hip and knee, also going to be included within cardiac for CHF. It's included in many other aspects as a common generic PROM. It's not specific to any one condition. And that we thought was also very important for Ontario health teams who may be targeting many different populations. So this isn't the most specific measure for heart failure or COPD or diabetes or urinary problems. It is a generic item that collects common and able to put things on a common basis irrespective of the population of choice. We'll talk a little bit more about this after. It has these 5 dimensions to it around people's ability to do their normal activities that they would aim for. We also have, Kaileah, next slide, the overall self-rated health item. And this is, overall, how would you rate your health from poor to excellent, as is one of the most common items anywhere in the world. And we have also added into this the patient health questionnaire. This actually arose partly in conversations with Ontario Health and their group as they seek to include this. And it really gets at the fact that the EQ5D is not quite as sensitive in the area of mental health. And so this allows us an extra bit of sensitivity. And it has 2 items related to little interest in activities and feeling down or depressed. It's a very validated screening tool for depression. And we use it here just as has also been used as an outcome measure in a number of studies. Okay, so that's going to be the measures that we're talking about in terms of PROMs today. Next, I'm going to describe very briefly what the population is on which we've drawn. So we have 2 primary OHTs that are participating, many others, a few others signing on. Some have started data collection. So overall, 4,000 people have clicked in and told us who they are. Only about 3,700 have completed the survey in its entirety, but still quite a sizable sample population. You can see that they range in age. We haven't had anybody over 75 respond to the survey yet. But these are all the age ranges, mostly in the middle ages. And you can see slightly more women, 63% identifying as a woman as opposed to 30% as a man and 1% as other. Next slide. These are the current results in terms of the race and ethnicity. Obviously, this is not representative of the population of Ontario. Certainly where I live here in Toronto, it is not representative of the population in Toronto. The vast majority of the respondents to date are white, and then you can see a smattering across many others. And as more OHTs, particularly in more urban settings, I would expect, begin to participate in this survey, we're going to see many more. I'm not going to present results according to race or ethnicity today, but we would expect and hope to be able to do that in the future as more OHTs are using this survey. But we do see that there are people from every or from many different race and ethnicities. Again, we are collecting this with the intention of using it to understand how this may be affecting people's experience and outcomes in health. Go ahead, Kaileah. Great. So I'm just going to start off and go through some of our results to date right now. Overall, the self-rated health at this point in time is shown on the left. So only about 4% of people saying that they are in poor health, about 12% in poor or fair health, and most in that good or very good range. I'm a little surprised, and we'll have comparative data for Ontario soon, that we only have 15% reporting it in excellent health, and I would hope there's opportunities to include and advance. And I see some questions coming up in the chat that I'll get to along the way. The EQ5D, here are the aspects of health, again, from no difficulty to extreme difficulty in each of these dimensions. And you can see that these would be relevant to different patient populations. So for example, frail older adults would probably be more interested and have more sensitivity to that area around self-care, which deals with activities of daily living. People with arthritis or other conditions may be more into that mobility or usual activities. We see the more common issue that people have in general is in the area of pain or discomfort, where a good sizable part of the population says that they do have slight pain or discomfort, and not too many, but still some saying that they have moderate levels of difficulty there. I'm not surprised, depending on the day I might report some pain and discomfort as well. On to the next slide. Just there's a bit of background to give you some baseline for interpreting what we're going to put up a little bit later on. This was on the self-reported mental health questionnaire, and the questionnaire asks about the frequency in how often people experience these. So not at all, just over 60% never experiencing or not at all experiencing either of these mental health problems, which is good news. But we do have 13 or 11% who more than 1/2 the days or nearly every day are experiencing either little interest or pleasure in doing things, or feeling down, depressed, or hopeless. This is useful and interesting for us to know here on a population level, but I can come back to this a little bit. Where we would like to get in this world of patient-reported outcome measures, and particularly on items like this, is that this information is available when patients go and visit their providers, that the provider can know about this. And so it's embedded and built into the electronic health record that they've responded, and this is their most recent response. And so then the provider can think about what the referral tools, and we need to make sure that providers have referral tools in order to help address patients' needs, either to address it directly themselves, but we have definitely seen primary care in past surveys identifying that they don't really know what to do about this sometimes. And so making sure that there's a clear pathway. But the real value in patient-reported outcome measures is when they become used by patients and by providers in their encounters to help direct their care. As of now, it's useful for us to be able to identify, are there issues as they relate to these different conditions? And that's going to be how I provide this information today, is around, and what do we know? Does it seem to be an issue here in Ontario among patients participating in Ontario health teams? Okay, go ahead, Kaileah. Great. So just a couple of key ways there, multiple ways to be measuring health, including overall self-rated health. There are advantages to that EQ5D5L because it taps into the different aspects of health that are important to different populations, and offering that common standard. And then having this PHQ-2 to be able to specifically identify depression-related symptoms to compensate for that low sensitivity. Just summarizing some of the points I had from the out point. Now I want to talk a little bit about equity. And when we think about equity, we think that it's really important to be thinking about the social determinants of health. And we identify these on the next slide as being those related, first off, we thought, those related to income security, food security, and housing security. Previously we have some research that's identified, for example, food security being highly related to becoming a future high-cost user, income security being related to use of hospital services. And these are related items, but they're not entirely overlapping. Correlation among these items in this survey to date, it ranges from 0.48 to 0.59 to give you a sense. So there's correlation, but they are not replicating each other. There are other social determinants of health, though. And on the next slide, I have increasingly become aware of the role of social isolation as a key factor that's associated with many health outcomes. And there was a tweet out of the Metropolitan University on the weekend that they have a new report out on social isolation and its role. I was at the, and so I encourage people to go look for that report. I was at the International Conference on Integrated Care, and there was one of the vice presidents from Alberta Health Services who had put up a chart looking at, or a graph looking at factors related to being a high-cost user in Alberta. And the strongest factor that he had found and his teams had found was social isolation. And I'm like, okay, well, how does this affect people's outcomes? And so we came back and we were looking at these results, and I'm going to show you some of these. I think we can say that social isolation should be acknowledged as a social determinant of health. And we're using the Stanford Social Isolation Index as it's the most widely applied measure. And the short form includes 3 aspects of isolation: feeling isolated, feeling left out, and lacking companionship. Again, these are related, but not entirely overlapping items. Correlation among these items is 0.62 to 0.76, so higher than the other income, food, and housing security, but still they're not the same, and they should be related. They're all around isolation and things that would be related, but they're not quite the same. So I'm going to report in various ways all 3 of these today. Next slide. In order to assess the extent to which these measures of social determinants of health may be an important factor related to PROMs and also to PREMs, we include these as a measure. And here I'm going to highlight the overall distribution of social determinants of health in the current respondents, and then we'll start looking at it as a stratifier to PROMs. Kaileah, the next slide has some of the key. So on the left, we see these food, income, and housing security items, and that's among the current respondents. How many people never have a problem with this? How many people rarely have a problem with this? Sometimes or always. So we see that on those like income, food, and housing insecurity, fortunately, there's a very small proportion of the population that always have an issue. But I was a little surprised actually on that housing and difficulty paying bills at the proportion that sometimes, it's 16, 17% difficulty paying bills, and about 14, 15% worried about losing their home. So keep that in mind as we start to look out that there are people in Ontario that are having substantial challenges. On the social isolation side of things, we see that there are, in fact, a minority of people who never have a problem with feeling isolated or feeling left out. And a substantial portion are in that rarely, but a good number of people sometimes or always either feel isolated. That is, almost 40% of our respondents so far, about 30% feeling left out, and about 27% lacking companionship. So these, not only are we thinking this might be an issue in the area of social isolation, it's also quite a prevalent issue. So onwards to see how this is related to our outcome measures. You can go right ahead to showing these results. Okay, here's our overall self-reported measure of health, and with the one item of difficulty paying bills at the end of the month, which would be our measure of income security. This would be people who are often, for the people who are always having difficulty, those are the people who are going to food banks. Those are people who are having many other issues in their lives, also housing. But really, this is the one where difficulty paying bills, and I've heard a good number of stories around how difficult people are finding it. And, with inflation right now, it's getting worse. So how many people have fair or poor health if they never have difficulty paying bills? Only 10%. But as you go down, rarely, sometimes, and always have difficulty paying bills at the end of the month. The people who always have difficulty paying bills, 30% of them are in fair or poor health. There's a very strong, that's 3 times as many as those who never had difficulty. That's quite a massive difference. So clearly, this income security is highly related to patients' overall self-reported health overall. So the next slide shows them across all 3 items, and we see similar patterns in the income and in the housing, so the far left and the far right. You actually see a slightly different pattern in the middle because we haven't reverse scaled this. This is exactly the way the question is asked. So do you have money left over for paying bills at the end of the month? Here, always, that's actually the positive response. And so those people have the smallest proportion that are in fair or poor health, which is why that graph seems to run a little bit opposite the others. But again, seeing this sort of similar gradient across all 3 of these, particularly the housing and the income security, and then the money for food security. It's a little stable on the never, rarely, and then increasing impact in sometimes and always having money left over, that it becomes less of an issue for health. Go ahead. Here's our results related to social isolation. Just remember, it was about 10% and 30% on the 2 extremes of the income security. We see something similar, but actually of a greater extreme. If you never feel socially isolated from others, only 7% of people are in fair or poor health. And if you always feel socially isolated from others, 35%. So that's almost 5 times the great as opposed to 3. So isolation and self-reported health are even more strongly related to each other. And if we look at all 3 measures of isolation on the next slide, we see they all trend in a similar direction, although the magnitudes are slightly different across them all. So clearly a similar common pattern here. Again, noting that these are related but not exactly overlapping items. Each of them are clearly having a contribution towards overall health or a relationship and association. And I see the chat that this could be even more exacerbated amongst the older adult population. And I think that would be true. We haven't been able to look at that quite yet. We'll get to it. So, I'm going to, I think, keep going and then come back and read some of the chat. But I think, really clearly here, we're seeing that self-reported overall health, and I've picked this one measure just to be clear. If we look within the other PROM measure of the EQ5D5L, we see similar patterns, just a whole lot more data, and the message is more difficult to convey. But I think we can say both income security, housing security, food security, as well as these 3 items related to isolation are clearly related to people's outcomes. We have the other measure of mental health. So let's have a look over at mental health. Thank you, Kaileah. And so on this time, I'm putting 2 up at the same time. On the left, we see the difficulty paying bills. And on the right, we see the socially isolated from others. And oh my goodness, when I saw this result, I was like, oh, I guess I wasn't completely blown away, but I was, quite concerned. So do you have, nearly every day or more than half the days, according to whether you have difficulty paying bills? Look at that, from less than 10% to almost 40% of the population having problems in those two areas of little pleasure or interest in doing things according or associated with them having difficulty paying bills. And, perhaps less surprisingly, but if you, were feeling isolated from others, not at all, that's going to be, 82% of the population who never feel isolated from others never have a problem with little interest or pleasure. They're generally well maintained. But if they always feel socially isolated from others, then we're looking at 95% of the people are having little interest or pleasure in doing things if they're always feeling socially isolated. Oh my goodness, how massive is that? It's a real issue. And I'll say that on the next item, Kaileah, you just saw the next slide, it's a very similar pattern around this feeling down, depressed, or hopeless item as well. So clearly mental health being very significantly related to difficulty paying bills, and even more so to isolation. So perhaps we shouldn't be surprised by this, but the magnitude, I think, is the thing that I found quite striking. The other thing I'm going to say, as I reflected upon these results when we were looking at them, two things is, one, we need to be well aware of the social determinants of health, both those income-related items and isolation. The other thing is that on this one, where we see the actual magnitude is stronger in the social isolation, the one piece of, I don't know, comfort is not the right word, but yeah, I'll go with that, that I can feel here is that actually I think that maybe social isolation might be more amenable to intervention, or might be more remediable than income, housing, or food insecurity. I think there's something a little bit more tangible about what we can maybe do here to identify individuals and to help. And maybe by helping, we'll be able to have an impact on mental health. And maybe by having an impact on mental health, we'll also be having an impact on physical health for these individuals. So let me just leave that as to what can we do. And I think in the area of isolation, maybe there are some things that we can do. And let's think about those. And I think that we're going to open up the chat pretty soon about ideas around what can we do. And I know many of you are doing things, so what are you doing? So I'll just have a few summary comments here, and then I have one or two more data points. So summary comments is, first off, is to realize the magnitude. So social determinants of health are clearly related. I think those graphics, I don't need to make them more blatant than that. I'm just showing you the data that we have. They're also statistically significant. So we've done the statistics, and they're statistically meaningful. So in terms of significance, all of the p-values for everything I've shown you today has a statistic that is less than 0.001. That is largely, that is very significant. And the Kendall's tau values, which show the association, are above 0.2 for income and housing and insecurity measures, or about 0.17 for food insecurity, which is considered to be moderate. And they are all statistically significant with Kendall's tau values above 0.4 generally for the social isolation, which is considered to be a strong relationship, or even potentially a very strong, but certainly a strong relationship. So statistically, as well as just heuristically meaningful. I wanted to put that out there. Okay, Kaileah. On the next slide, we are talking about the outcomes quadrant today and health outcomes. And we talked about patient experience 2 months ago. And at the time, we hadn't analyzed the social determinants of health data to the extent that we have now. And also we had many other things happening in that monthly webinar, and I didn't bring up these results. But I just want to step back. We're talking about patient-reported outcomes, but we also have looked at these for the experience measures. And I'll say that there are some statistically significant and meaningful relationships among the experience items. and particularly as they relate to having someone to count on and knowing what to expect. And to some extent also the overall coordination of care. I will say I was heartened as we did all of the analyses that while there were some statistically significant relationships, we have a large enough sample size. When we looked at items related to access to care, which was the first one, you can easily access care in the overall patient experience, we actually saw very little relationship with these social determinants and access to care. I was heartened by that. Okay, so I'm just going to put up the one result here that we're going to talk about around experience, and this is the one where it was related somewhat. You can see it's a lower gradient on the left with income, security, and experience. So people are having a similar experience of care regardless of their income security, which to me speaks well, at least in the OHTs that have participated so far. We'll see what it's like elsewhere. That we have some, but less of a gradient in terms of being able to have a good experience of care. And this is a question around having someone to count on, that the healthcare provider will check up on me to ensure needs are met. This is happening regardless of people's socioeconomic status. Unfortunately, it's not the same across people's social isolation. And people who feel that they are always socially isolated have a lot less confidence that their healthcare provider is going to be checking up to ensure that their care needs are met. I know whether that's perception or whether that's just their ability to stay in touch and feel reassured, I don't know, but it is certainly a perception that people have. So again, the access to care was not as much of an issue, but on the experience of having someone to count on, it was more of an issue here. So that's what I have to say here around equity, around PROMs and PREMs. Mental health conditions are concerned. These are highly related to social determinants. The social determinants are important determinants, both of overall health and mental health, and that the social isolation has a strong association with PROMs and PREMs. And from here on in, you're going to hear me talk about this as a core social determinant of health. And I think the rest of our team as well. I think there's been a lot of chat that I'll get to. But if you go ahead, Kaileah, I think we have a prompt for chat. And then, yeah, so do you think it's important or useful to measure these social determinants? And do you think also that it's important to have a common approach to this measurement across Ontario health teams? So maybe with that, we can take down the slides. We'll come back to doing a poll later. And I'll just want to catch up on the chat because there's been so much.
Yeah, I wondered if we could start out, there was just some questions, I think in clarification of the data source, sort of where patients would access this survey and why it isn't representative of the provincial population at this time.
So we have, and so tried to advertise this as fair amount through these monthly events and otherwise as possible. You can go to our website at hspn.ca, and from there find our work on OHTs, and at the bottom of that page you'll see patient and provider experience surveys. We've developed common tools for all OHTs to use for both providers and for patients in order to complete the quadruple aim. You can see a version of the survey there, and we also have a video there on how to access. We are supporting OHTs to collect this data across all Ontario health teams. And if you want to do that, all you have to do is send us an email to oht.evaluation. Those instructions are on the website, and we will set your OHT up with a tailored version of this survey to distribute amongst the individuals in your OHT. And there are many ways people are using this. Our largest sample, people saw South Georgian Bay come on a few months ago and talk about their experience. They distributed it to everybody in their attributed population who is attached to their primary family health team. And they use that as an avenue to distribute this by email. Another OHT is individually going out to individuals and distributing it. In fact, even having volunteers help them to complete it for frail adults. Other OHTs have various ways of distributing the survey out there. We have this sitting on an electronic platform in REDCap. Happy to do that for you. If you want to use it in some other way, there's a PDF online, and you're free and welcome to use any of the items related to that tool. So that's how to use and how to access. Any further questions, oht.evaluation@utoronto.ca.
There was a couple of questions around the social determinants of health. I'm wondering if you can comment sort of a little bit on the source of the selection, because there were some comments that there's some items like language or maintaining relationships that are also determinants of health.
Absolutely. We are not comprehensive as to all of the social determinants of health, and maintaining relationships is, and if you have the full, that Stanford started out as a 30-item questionnaire, then there's a 13-item, and in the 13-item, it does have questions around maintaining relationships. And I'll say that a countermeasure to social isolation is also social cohesion. So if people still feel a belonging in their communities and their neighborhoods, they are better off, even if they do feel socially isolated, because they can still feel a belonging, and that's a little bit of an antidote to this space. We didn't include all measures in our survey, again, just because we're trying to keep it as small as possible. Already people asking about how big it is.
Another question around the EQ5D tool. So that's sort of embedded within the survey, but there's a question about whether that tool will become available to OHT members in hopes of harmonizing our survey. So maybe we can touch on the harmonizing aspect too.
Yeah, so I mean, we have permission and license to use this EQ5D5L in all of our work. We've obtained that permission. You can directly work with the EuroQual group to obtain that permission yourselves, or I'd recommend that you use our tool. Then you have a couple of advantages. One, you get access to the tool. Also, you get comparative data, because as we start to collect this from OHTs, we'll be able to provide that comparative data out across OHTs. And we will be in a position, if you're using our backbone data collection, because it'll all be available electronically to us and to you. We also hand the data right back to you for participating. So we're not keeping it ourselves, we're giving it back to you. It is your data. Any others?
Yeah.
I see a lot, so.
Yeah, there is a lot there. There are a couple of people commenting, I think, on kind of some of the contributing factors that might relate to the results. You mentioned one earlier in terms of age, or also access to digital care or internet.
Yeah, so we have collected information. We are using this tool. So right now, our method of collection, and we actually weren't empowered to do this at scale. We did it because we saw the need. And the only way we can do it here is digital. I will say that recently for HealthLinks, we distributed a survey to all HealthLink individuals in one of the previous LINs, and older adults actually found it easier to be able to use the digital tool than the paper-based version, because they could change the font size. They could have somebody help them, and they could actually have an accessible digital tool. So it actually made it more accessible. There are some people who wouldn't have access. I mean, I think intermittent internet access is not a barrier here, because these survey tools don't take up a lot of bandwidth. It's not like trying to run a video chat. But in some ways, having a digital tool enhances access. I realize that everybody does not have connectivity. You can print it out. One of our OHTs doing this work is sometimes delivering, and in fact, South Georgian Bay also printed it out and distributed by mail to many of the people who they didn't have emails for, and collected and entered that data themselves. I saw a question about the geography. The largest survey response area is for South Georgian Bay, with over 3,500, I think, of the responses so far, and another, Central Ontario, Central Northern Ontario. We don't have urban sites launched yet. We do have, I believe, at least 4 urban sites who have signed up and have links to be able to distribute the survey. I don't think they have distributed it yet. I might be wrong on that. I've been away for a week, so.
Walter, there was also a comment made by someone in Simcoe County. They're looking at this issue of social isolation. So they're working on a focus group to better understand the issue because of the impact COVID just exacerbated this among older adults, among the over 75 group, I'm assuming, because that was a comment that, we don't have a lot of information currently on that group.
And it's not a rural issue only. It's very much an urban issue. And in fact, I'm not saying you're saying that, I'm just making the point that in fact, urbanization has increased the level of social isolation So it's really actually true that as people move to more populated environments, they don't interact as much with their neighbors as they do in more rural circumstances, and it can become even a larger issue. So we're talking about this, and you're talking about Simcoe County, which would actually, I think, possibly include Barrie within Simcoe County. I'm not 100% sure, but so it's many areas. Yeah, the results do not include people from large urban areas. Yeah, so there you go, Catherine.
Oh, sorry, there is a highlight, I think, in response to our question about whether it's important to have a common approach. One person highlighted that it is very important to have a common approach. And another one highlighted that the common approach should have a short survey that's easy to use. I'm wondering if you comment on length or
yeah,
that concern.
So, we have a few more things to cover today. So why don't we're going to get an audience vote on the length of this in a little bit. So I'm just going to come back and maybe if you can bring the slides back up, talk about a couple of limitations, and then we're going to have an audience vote on the length survey. Okay, so are there limitations to this survey? Oh my goodness, I don't have time to go through all the limitations to this survey. This is not the first survey we've built. In fact, we just released a 5-report summary of work that we did to develop a home and community care. These are hard to do well. Couple of limitations that I'll just mention here. Wording is aligned with the Ontario Healthcare Experience Survey in order that we would be able to have comparative data. I've reported out on how things are going in evaluations before, and anybody's like, oh, so is that better or worse? And I'm like, I have no idea. So we're aligning with the Ontario Healthcare Experience Survey so we can know whether OHTs are making a difference and improving over time with respect or as in compared to the general Ontario population. That means that we had to tweak the wording a little bit to align with theirs in some ways that we might have preferred not to. Some sections of the survey are more relevant to specific populations. We ask individuals, if you've used the emergency department, what your transitions in care were like. If you've used the inpatient, if you've had an inpatient admission, what that was like. If you've seen a specialist, what that was like. If you've seen a lab, what that was like. And so there are many portions of the survey that are relevant only to those people who have used those services. We could probably shorten the survey by asking people if they wanted to report on those. Right for now, we've said, if you had those experiences, then we do want to know about your experience. For people who haven't had those services and haven't used emergency departments, acute labs, or specialist care, they can get through this survey in about 20 items. So it's pretty brief. We did add some questions on digital health with the advent and e-health access to care through virtual means as a result of during the start of the pandemic, thinking that that was going to be important. I'll come to you for a vote on the importance of that or not. So yes, we are fielding the tool as it is right now. We are thinking of ways that we can make it, I would say, more responsive and more person-centered. And by that, I think we are wanting to make it that people will have greater choice in which components of the survey they respond to. So I think we should keep some of those portions available, but we should make it more optional as to whether individuals responding to the survey want to respond to all those different dimensions. And so we'll make it person-centered that way, rather than actually forcing them to do it or removing the option for them to do it. That's my perspective on that right now. The other thing is we really need to do more field testing. We developed this survey before OHTs had begun to deliver services to individuals in the community. Now that OHTs are beginning to deliver services to the people in the community, we need to see that it's still responsive and useful to those populations. We consulted with patients, caregivers across Ontario. They were those that were involved primarily in the planning of OHTs. Now we need to be consulting with patients and caregivers across Ontario who are receiving services from OHTs. So that's just a few comments, I think gets out a little bit to the length. And now, Kaileah, if we can go to this next poll, I'm not sure if it's you or Anne that is going to be able to launch the poll. Here's my question. Which of the following should be included in an OHT patient survey? And here's going to be a list of options, and you get to choose, and you select all that you think you would want. The health services that are used, so you know which parts of the health system people are using when they're responding. Should we have these patient-reported outcomes? Should we have the experience measures aligned with the 6 attributes that I talked about before? Easily accessing care, having someone to count on, being heard, and knowing what to expect. Should we have these transitions-related questions relating to specialists, laboratory, emergency department? Should we have digital and virtual care options in there? Should we include these sociodemographic, including age, gender, ethnicity, and social determinants of health? That's 9 questions we have in there right now. Maybe we could reduce, but I think we're finding value in each of them. And we also have an open-ended comment for people to identify opportunities to improve care. So 181 people out there, I'd like to see as many respondents as possible here, because it will help drive what we do and don't do with this survey in terms of the important aspects. Yep.
I was just going to say, while people are filling out the poll, I'll just make a comment on your last comment that the length of the survey and consistency was something that we, a question that we had in the last webinar on when we were going over the provider experience and highlighting that while it is nice to have an overarching measure that's not so burdensome to collect, when we have the additional information, there's an opportunity to explore relationships between the different items and really get an understanding of the full picture, and therefore the data are potentially more actionable in terms of targeted planning after. So.
Yeah, and I see Matthew Grevlin commenting in here about having a bias to make everything, but how to make it user-friendly. I'm not sure, Matthew, if you've had the chance to go in and actually try it out. REDCap is not the most beautiful survey tool in the world. We had another tool that we were using previously that had a better sort of user interface, and our leadership survey for Ontario Health Teams sits on that Hosted in Canada platform. It has a little bit of a nicer couple reasons that we've used REDCap for now is it's a little bit more secure sitting behind our U of T firewalls. And like even for me to go in and look at results, I have 2-factor authentication. So the data sit a little bit more securely. So we're covered under a Research Ethics Board approval. It makes it a little bit less user-friendly. I'm happy to have options. We don't have a budget for this, so that's another consideration. But Matthew, if you're interested or anybody else is interested, please contact us. We would love to have design issues around how do we make it accessible and user-friendly. And the language, you know, Rosie, Yoon, I see, you know, we have a negotiation to have with the Ontario Healthcare Experience Survey as well. We don't always have, some question we have optimal wording on, and they changed for us, but that was a bit of a, you know, it's a negotiation. So for us to have comparable, and you know, maybe if we have all OHTs participating, that comparison to the other parts of Ontario is good enough. I think our results are probably pretty stable now, Kaileah, so we could probably post. The transitions in care and the digital and virtual care have the lowest support here, 64 and 67%. 70% say an open-ended question is useful. That's still relatively high. And the other items we have clearly very high consent. You know, one of the things I didn't put in here, and maybe we will think about, is this person-centered approach where people are enabled to respond to those portions of the survey that they feel they want to. Can someone post those results? They didn't get shared? Oh yeah, I think they should be shared, Sandra. I should be able to see those results.
Yeah, you should see them now. I think there is a mix-up. But
okay.
Yeah.
Thanks. A couple others here. I think that a language problem ourselves, people today are not talking about patients. Yeah, you know, actually I had, I was gonna raise this myself as an issue in terms of having whether we call this a patient survey. When we designed it, and I think it should be a person-oriented survey, we expect at this point in time that every individual receiving the survey are likely to have been a patient or known to be a patient as such to a provider in the Ontario Health team, but very interested in other descriptors that we can use in terms of this survey, other than calling it a patient survey. As of now, it asks about health services use. And I think if we were talking about people who didn't access care, and that's something we might want to do, we need to think about other language here. But anyways, that was a little bit about where that language around patients came from. At the beginning, I believe in person-oriented care, not patient-oriented care. I believe in person-oriented surveys, not patient-oriented surveys. But other suggestions are going to be very welcome to you.
Great. So there's a number of, I think we've addressed some of the main questions in the chat, and there might be some others, Walter, that you can check out and respond in the text. And I will move us along to the next portion of our talk, and we'll hear from Ruth on using different data, so using health system data as a proxy for health outcomes. So take it away, Ruth.
Thanks, Kaileah. Hi, everybody. This is going to be similar looking data that you saw probably just over a year ago, and I've got up here on the slide the reports that have come out in the past. We identified several attributed population, entire attributable population improvement indicators, and then for those most common priority populations. So I'm not sure if everybody was able to see an email that was sent out for those OHTs that have seen these in the past. So cohort 3 has not got these reports. That your numbers of your OHT. These are all anonymized, so you can look at your most recent reports. You saw this data, or this data is available to you when we came out to do our presentations on CQIP and population segmentation. In your Excel files, you will see this information there, 1920 and 2021 data that I'm sharing some of it with you on these slides. Next slide, Kaileah. So today's quadrant is patient and population outcomes. We just heard from Walter, the patient reported outcomes. We can't get that everywhere. You saw how limited our sample is, whereas our proxy measures that we get from the health administrative data allows us to look across the entire province. So that, it's a trade-off. It's not actually a patient outcome as people like to think about, but in terms of the system, these are measures of outcomes of care and well-being. So they are an indirect measure. So to refresh our memory, thanks, Kaileah, we had 10 indicators that were reported in previous reports for the entire OHT attributed population. I'm going to share with you today premature mortality and ambulatory care sensitive hospitalizations, and due to time. We've selected one for each of the priority populations that OHTs had identified in their full applications. The palliative group of patients, end of life care, where I'm going to look at deaths in hospital, and then our repeat ED visits within 30 days of a mental health and addiction ED visit. We talked a lot about the CQIP indicator, so we're not going to talk about that one again today. And the older and frail adults, we're going to look at the change in the health status quality of life measure. Next slide, please, Kaileah. So we always look at equity, as Kaileah presented at the beginning of this webinar, that we always take an equity lens. It's important to look at the differences in these outcomes across different levels of equity. The patient client survey allowed us to have different measures. With administrative data, we are limited, of course, with using census information, so it's not individual measures of material deprivation that we're looking at, but it's ecological, small areas. So we use the material deprivation index. And to refresh your memory, this is aspects of income, education, family structure, single parent households, and quality of your housing. And you can see, again, this is an updated slide. This is a 52, 51 currently approved OHTs, and we can see the variation by OHT, where some OHTs have, you know, a good 40 some odd percent in those most deprived areas, and other OHTs have 50 or more percent in very affluent areas or less deprived. And this indicator has been associated with poor outcomes, and so this measure of equity has been associated with poor outcomes. So that's our other rationale for selecting this. Okay, next slide. So I'm just going to refresh everybody's memory about understanding and interpreting these scatter plots. Excuse me. Each panel, which means the year, represents the OHT's risk-adjusted estimates calculated for each period of time. And we order things from left to right, the left side always being more desirable outcome, and based on the most recent year of data. So that's 2021. And if we want to remember that, that was in the thick of COVID-19. So our ordering, therefore, no matter what panel you look at, is always the same, the ordering of your OHT. So it allows you just to look, you know, your eye can move up or down to look at the previous, to look down at the previous year, and it's always in line. And the color of the dot is according to your ratio in your OHT of your attributed populations, the proportion of them that are in the most deprived areas versus the least deprived areas. So the darker the blue represents OHTs with a high proportion of their attributed population in the most deprived areas, as compared to the proportion of their attributed population that lives in the least deprived. So your light green represents those OHTs where there is a higher proportion of people in the least deprived area compared to the most deprived. So just a little refresher. So looking here at premature mortality in 2021, the rate per 100,000 population was 318, which is an increase that had to previous years where it had been relatively stable around the 300 range. Although that we see an increase, there are some OHTs where there has been improvement observed. And what also is important here is that your premature mortality is moderately correlated with material deprivation, suggesting that those OHTs with higher proportion of their population living in the deprived areas generally have higher premature mortality rates. And you know, this also shows that there is you know, variation here across our OHTs in the rate of premature mortality. Next slide, please. Now on to the ambulatory care sensitive conditions. They reflect chronic conditions which, if treated and monitored effectively in the community, they should reduce the likelihood of a hospital admission. People don't like to be hospitalized. So, you know, a poor outcome of being hospitalized for these kind of conditions that could be managed effectively in the community. And it also is reflecting access to primary and specialist care. So in 2021, we saw a decrease compared to the previous year. In fact, it was around 27% decrease from previous years. And we see wide variation across the OHTs, a threefold variation almost, and from 173 per 100,000 to 486. And we also find that these types of hospitalizations are moderately correlated with deprivation. You can see in the upper right, there's a lot more of the dark blues and medium, the darker blues at the right end of this league table compared to the lighter colors. So there is some connection here with material deprivation and being hospitalized for ambulatory sensitive conditions. Next slide, please. So just want to put it out there for some discussion. Have any of these been discussed at your OHT tables? And do you think we can maintain this level of reduced ambulatory care sensitive hospitalizations? And what do you think might be contributing to this decrease? I mean, we did have COVID, yes, and it resulted in some increase in our virtual visits and monitoring. I'm just curious to hear what those on the line or on the webinar are thinking about this indicator, and is it being discussed? Any comments here? I'm going to open the chat. Yeah, deaths owing to COVID. Yeah. The premature mortality is, though, for those under 75 years of age, we did see a large proportion of deaths, sadly, in the older population. I think opioid deaths are also been of concern through the pandemic as well. So Robert's saying we haven't discussed explicitly. Again, COVID reality has changed hospitals visits quite a bit. Yeah. It'll be interesting to see how well these ambulatory sensitive conditions rates change over the next year or two, and whether we can keep it at this level or continue to go lower. Yeah, and ED, thanks, Karen. That report shows that ED visits during COVID had decreased 37%. Yeah. And emergency volumes down. Thank you. So maybe we'll go on to the next set of indicators. So just, again, remembering that this is important to keep in mind when you look at those dots, because just in case you notice any dot colors change from indicator to indicator, they generally don't. But for the end of life, we're only looking at those that die in the year of the reporting. For mental health and addiction, it is looking in general of your entire attributed population. And then our older frail adults, it's usually, you have to be the general population here is those over the age of 65, and our health-related quality of life measure is finer definition, being among those that are on long stay home care. So just to remind everybody that they do change depending on the indicator in these priority populations. So we'll look first of all at the end of life palliative care. That was a popular priority population. And we see that, this is an indicator that reflects that most people do not want to die in hospital. They prefer to die at home. And we see that the rate of in-hospital death in the 2021 dropped from 50% in 2019-20 down to 46% in 2021. And ranging from as low as 32% to 50%. So again, the unique year in 2021. So it's really going to be interesting to see how things shift in the go forward. Is this, again, a desirable rate to keep steady further, keep working to decline. I just think it's really interesting what 2021 is showing us relative to the past. So it'll be interesting to see as we go forward. Next slide. So this palliative care section, I'm just wondering if this indicator has been discussed at your OHTs tables. And as I mentioned, is this something that we want to, keep driving? We were able to get it down, or is it down for the right reasons? So what's contributing to this decrease? Is there an opportunity to reach out to some long-term care facilities during, we saw what happened in COVID in the long-term care facilities, to engage them in discussions about place of death for those at the end of life care, and what supports are needed. Any other, so I'm going to open the chat here. I think we can, I think we just keep measuring and look at what happened before, during COVID, and there is still no after an alternative. Stop measuring. That's Walter's response, I guess, to Sharada. Thanks. We can't look at 2020 without understanding, yes, exactly what happened in long-term care. So that would be our OHTs thinking more about engaging with long-term care facilities at their OHT tables in dealing with their their elderly population, as well as end-of-life care. Okay. All right. I'll go on to the next slide. Mental health and addictions. This is the rate of repeated mental health and addiction ED visits within 30 days of an ED, mental health and ED visit in the year of reporting. Because again, this is not a desirable outcome for patients to have repeat unscheduled ED visits. And because it may be reflecting inadequate transitions from hospital to community care, or for some reason, inability to access community care in a timely fashion. So we saw that the rate of this particular indicator in 2021 increase up to almost 24%, rate with a threefold variation across the OHTs. And this is up from the low 20% mark in 2019, 2020, and earlier as well. Again, just any conversations about this happening at your OHT tables around this particular indicator. So then we can go on to the next slide. Thanks. So then our other priority population were the frail older adults, and an outcome measure that we can get from routinely collected data to allow us to compare across all the OHTs is often found in our RI assessment tools. And this change in health status is an important one because it's preference-based, it's health-related, and it's derived from several measures within the RI instrument. And it allows a single summary score across various domains of health status. And it ranges from minus 0.03 to 1, and 1 being perfect health. And when we see a difference of plus or minus 0.03, that's said to be a clinically meaningful difference. And it's important because we want to slow the decline among older adults, and these long stay home care patients are typically these older adults, and they require a multifaceted interventions to slow that decline. So in 2020, the mean change we observed was a drop in function in status of sorry, that's a mistake. That should be 0.04 change, and it ranged from 0.02 to minus 0.12. The period of time this reflects is there was one assessment done in the current year or previous year. So in 2021, that assessment could have happened in 2019, and we looked for the second assessment within 365 days. So it's quite stark change here, I think, especially when we look at those at the right end. There are really big drops in the health status, and again, this I think speaks to maybe the isolation issue that happened among these older adults through the COVID year, and hard time getting out to activities, or people coming into their homes to give them the care that they need, as well as social engagement as well. So this is quite remarkable, I think, that we see this dramatic drop compared to the previous year. Next slide. So I again, just sharing with you one of the 5 indicators that we had identified among those priority populations. That, again, are these being discussed at your tables. And for those OHTs who have seen a dramatic drop, what might be contributing to these declines or increases that we saw in the mental health indicator? Open up for any conversation, thoughts. Yeah, access to, yeah, exactly. Community services being limited during that year. And home care, yeah, human resource deficits are a real challenge for sure in that, particularly in that 2021 period. Yeah. Okay. I missed any others, and yes, improved access to hospice care would greatly reduce. Yeah. Okay. I just want to summarize here in the next slide. So is it, this 2021 year is going to be a very interesting point to make, looking back and looking forward. We saw that premature mortality increased. We saw an increase in mental health and addiction related repeat ED visits, greater decline in the health status index among those long stay home care clients. And we saw a reduction in ambulatory care sensitive hospitalizations. Are there new ways of delivering care that can keep people from being hospitalized for these conditions that could be managed in the community, that we can learn from going forward? And also this decline in deaths that occur in the hospital. And also just to note that we do see this moderate to strong correlation between material deprivation and premature mortality, as well as our ambulatory care sensitive hospitalizations, highlighting the importance of always bearing that in mind, that there are gradients, worse outcomes associated with those living in the more deprived areas of your OHT. And then I think, Kaileah, we can put up to a poll, and I can take down the slide and. Okay.
Yeah, we've got a poll here about proxy measures, and I'm thanks everybody to responding to those questions in the chat. It's always nice to get some on the ground perspective, and it looks like Walter's been fast and furious in the chat answering a lot of the questions, so that's great. So we have a poll running here, but we also have a question for you if you can answer it in the chat of what other proxy patient outcome indicators from routinely collected data do you think are relevant? So is there something, some key indicator that you find particularly relevant for your OHT, your priority population, or broadly?
Interesting. Polls going.
Yeah, we'll give it maybe 10 more seconds, hopefully, for people to respond to that poll. So we say Catherine Isaac highlighted 30-day readmission.
Okay.
Number of clients, caregivers requesting crisis long-term care placement.
30 remission coming up again.
So I'll end the poll now.
Yeah, so over 70% are saying these are very relevant or relevant. So that's encouraging. And suggestions to adding readmissions. Thank you. Time to primary care appointment. Yeah. There's another, thanks for the suggestions too.
Great.
And okay, what have we got here? So we've, our current state is that we rank all OHTs by performance and color coding to show material deprivation. And we have de-identified your OHTs. So question for the group is, do we begin in future reporting to start to identify our OHTs in reporting, do you think? And is it time to start thinking about peer grouping for OHT comparisons rather than just comparing across all of them and relative to the province? We just like to get a pulse on these future considerations of reporting back to OHTs. So is it time to think about peer grouping for OHTs? Yes. Resounding yes so far.
So we'll give people 10 more seconds to answer, or maybe 5. Really like to hear from people on this one.
Mm-hmm.
We have a question about how would peers be determined, so we can talk about that in a second when I share. So I'll just end the poll now. And fairly conclusive.
Yep. Great. So we'll put up our next poll. So you go ahead, Kaileah.
So we're interested in hearing from you in terms of what factors make an OHT comparable to your OHT, and you can select all that apply. And we do understand that this might vary from measure to measure in terms of who you might want to compare to, but I'd like to hear from you on this.
I think ideally we wouldn't want to have different peer groups for depending on the measure. We'd like to think about just, you know, we always going to have to make compromises, but if you had to choose one. Wow, there's a lot of.
So there's quite a few options here. I'll leave this one open a little bit longer, so people have an opportunity to think through the different options and what might be relevant.
Thanks, Ivy. Suggesting another option being cohort, what cohort you're in. Care attachment rate. Thank you, Amber.
Okay, so we'll give it just a couple more seconds and I'll end this poll.
Diversity in OHT, yeah. Okay. We're liking that classic urban, suburban, rural, remote. But you're picking all that applies. So yeah, and material deprivation. Interesting. Great. And the size of the attributed population as being the top choices. And we've got some good other suggestions as well. So thank you to everyone. Oh yeah, we've got primary, yeah. Focus population.
So there's two more questions here just to get your input and just in the chat, whether it's time to de-anonymize OHTs in reports. So right now, everybody knows who they are, but not the other OHTs, but this would open it up so that you'd be able to see whose results pertain to who, and just if you have any comments on considerations there.
Does focus population for the age? Focus populations, have we typically described it as based on the identified priority populations the OHTs have written in their application is what they wanted to begin their initial work as one integrated multi-organizational team. Where does age fall into factors for it? We do most of our indicator we adjust our indicators by age and sex to account for the different age sex distribution that could be present across the OHTs. Okay, chat. All right.
All right. So feel free to enter your chat there in the feedback. I think that the rationale there is in terms of comparison, and I mean, there's always also the opportunity to reach out to like people and discuss any sort of commonalities and problem solve. So there's one rationale there. Okay, so a couple extra comments coming in.
Yeah, I'm not familiar with the OHCPP data. Are you familiar with that, Walter? From Monroe Ross.
Those are the community profiles, but Monroe might have to clarify what that what it is. I think that those are at the level of community, which are geographic areas, which are not exactly attributable populations. That's my sense. To the people, you know, I think on the on the identifying OHTs, we kind of came out because when you first start reporting publicly on a new peer grouping that people are not familiar with, generally good practice to be providing it in an anonymous way so that people are just looking at the data and getting a sense, and yet everybody knows who they are. We can just ask individual OHTs to be willing to provide, and that's an option. We want to get a bit of a sense from other people, though, how this is generally going to go, because I mean, the value in being able to re-identify, everybody already knows who they are, but the value is knowing who other people are. So you can compare against other people, and to do that, we need, you know, all or, you know, almost all to be able to actually do that, to join in. So we just want to get a bit of a pulse on that. I do not believe that there are any legal restrictions from just having us do that. But, you know, we're trying to do this in together and just see that we don't get too far ahead of people. We also think that by identifying OHTs, it's highly important and valuable for us to be thinking about peer grouping. Because that is one thing, like, you know, comparing who to who. So if we provide some guidance around peer grouping, then we will hopefully avoid sort of less informed comparisons being made. we're going to be doing some work in this. You're going to hear from us again a couple times, some work to get some input on how do we do peer grouping. I think at the outset, my sense is that uncontrollable factors that relate to the outcomes, at least short-term uncontrollable, everything's probably controllable in the long run, should be things that we would consider in peer grouping. So things related to primary care outcomes may be considered grouping by primary care models. Things related to avoidable hospitalizations or things like that maybe consider possibly the size of the community that might relate to the other resources available to them. And then also material deprivation, because that just leads to a whole other host of challenges as people are discharged from the hospital. So, but we don't want to make it too complicated either. So that's, I think, some of the trade-offs that we'll have to make in the coming year. But our goal is to re-identify all OHTs and to provide guidance on peer groupings, and we want your help.
Great. Thanks, everybody, and thanks for your input in the chat. It's really helpful to hear from you. I think that's it for our content, and just highlight that we're almost done our tour around the Quadruple Aim. So next month, we'll be focusing on the cost value quadrant, happening the 4th Tuesday of the month. We also want your feedback on this webinar. So here's a QR code that will take you to a platform to provide just some quick notes, and we'll hopefully also get that link in the chat as well. Here it is, and oh, there's our team, and thank you to everybody. So thanks again. Thanks, Walter. Thanks, Ruth, for sharing. Thanks, everybody, for your input and your great questions in the chat. And hopefully we'll see you next month.